again. The next topic is cerebral visual impairment in children, causes and management. For this, may I request Dr. Suma Ganesh to please chair this session. Over to you, Dr. Suma.
Good morning and a warm welcome to our instruction course on cerebral visual impairment in children. So what does this course really help us? It will help us to understand CVI, multiple disability with visual impairment better, how to pick it up by identifying these red flags and then referring to the intervention specialist, and to create awareness among all ophthalmologists, the need to treat them early, and to highlight the small points to be incorporated in our daily practice in pediatrics. So we have 4 eminent speakers apart from me, and we have Miss Kristen Layton she's the director of Perkins India, an affiliated program of Perkins School for the Blind in Massachusetts. She specializes in education of children with multiple disabilities and inclusive education. She holds position at Boston College, the University of Maryland, and the US Department of Education National Deaf Blind Project and the Helen Keller National Center. She will be giving the keynote, but I will introduce the other speakers too. Paige Klotzman, she is the program manager of Perkins India, an affiliated program of Perkins School for the Blind in Massachusetts. She specializes in monitoring and evaluation of international development projects and programs. She holds a master's degree in development practice and a bachelor's degree in cultural anthropology. She will be telling us about how, together with Shroff, the Perkins and Shroff Hospital in Delhi, we have developed a screening module for multiple disability with visual impairment in children, how to help these children in the community, and how to assess them and how to treat them. We have Dr. Sovita Rath. She works with Shroff as a consultant in the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology. Her keen interest is in the field of neuro-ophthalmology, and we will see how she examines these children and assesses these children with problems. And she also has many publications to her credit. Mrs. Madhumati Bose, who is the main person in this work, I would say that she is going to talk to us how early intervention is important. She is a specialist in the field of early intervention in children with developmental delays and disabilities. She has 26 years of professional experience in this field. She is an international level trainer and has conducted a number of workshops in India, Bangladesh, and UK. So we will start with a recorded lecture of Ms. Kristen Layton on keynote lecture on intersection of medicine, neuroscience, and education in multiple disability with visual impairment. I'm stopping my share, and we go to the next talk. Sovita, can you?
Good morning, ma'am. Is the screen shared?
Yes, Dr. Sovita, it's visible.
Okay, so should I start playing it now?
Yes.
So with just the volume is not there.
Vision impairment, cerebral vision impairment.
It's not audible?
Yes,
yeah, audible.
Start by saying.
Dr. Savita, I would request you to please unmute yourself.
The limit. It forces educators to work with the medical community. It forces ophthalmologists to talk to teachers. It truly is the intersection of health, education.
I guess again we lost the volume. Dr. Savita, are you there?
Yes.
We cannot hear the audio at all. So I would request you to please restart the session again, restart the recording again.
Fine.
CBI, presented by some of the leading specialists in the field of CBI in India and some international guests as well. And the topics range from the more medical aspects of CBI to interventions and some educational supports. Before I get into the meat of what I'll talk about today, I wanted to give a quick shout out to Dr. Schroff's Charity Eye Hospital. As I mentioned before, CBI is a challenging and complex thing to take on as an eye hospital. Dr. Suma Ganesh and her team chose to take on that challenge many years ago and to see these children, to diagnose them correctly, and to provide the interventions and supports that those children need. Perkins is so pleased to be able to partner with Dr. Schroff's hospital to create even broader programs for the early identification, intervention, and educational supports of children with CBI, and also supporting children with vision impairment and other disabilities. When I think about CBI, I often think in terms of the following two slides. If you have met one child with CBI, you have met one child with CBI. And that really sums up a lot of the complexities of CBI, in that every child is unique and sees in unique ways and has a unique way of learning. I've been working with children who have CBI for over 20 years, and I've yet to meet two children that present exactly the same and who learn in exactly the same ways through their vision. So if you remember nothing else from this presentation, please keep that in mind, that each child is very, very unique. I will leave the heavy lifting to my colleagues to talk about the intricacies of CBI and some of the more detailed aspects. However, I would just like to cover just a few foundational pieces to set the stage. You'll see CBI mentioned as cortical vision impairment and cerebral vision impairment. I won't get into the controversy, but it means the same thing. It just depends on the school of thinking and some of the history behind CBI. So both terms are used interchangeably, and it's easiest to call it CBI. As most of us, as many of us know, it's a brain-based vision impairment. And when we see these children, many of them have healthy eyes, that the damage really is in the visual pathways and the areas of the brain that control vision. This affects their visual attention and recognition and causes them to have unique visual behaviors that aren't attributed to their eye function. CBI right now is the leading cause of vision impairment in the United States. The hopeful message here is that effective treatment can lead to improvement in vision in these children. In preparation for talking with all of you today, I thought about the intersection of health, education, and neuroscience, and thought that there's no better perspective than that of a family member of a child who has CBI. So I went to my colleague at Perkins, Rachel Bennett. She's a mom of a child who has CBI, and she's also a professional in the field. And I asked her if she had a few minutes to talk to the leading ophthalmologist in India. What would she say? What would she share with them? What is the most important thing for people to know? So my next three slides focus on essentially what she told me to tell you, to share with all of you. So the first is really the importance of early diagnosis. Too few doctors understand CBI, so it is often well underdiagnosed. Ophthalmologists are the gateway to information and to sharing information with families. Families, when they don't see their children seeing the right way, will come to an eye hospital, to an eye clinic, to the eye doctor. So often ophthalmologists are the first professional that the family is coming into contact with, and therefore are the gateway to getting the family further supports for their child. We hope to change the way we do clinical assessment, to go beyond the teller acuity cards, to go beyond a traditional clinical assessment, to look at more functional aspects of vision so that we can diagnose more readily. To ask the questions, are we capturing changes in visual behavior? Are we collecting the information and history from families that are often the clues that lead us to diagnosing a child with CBI? And eventually, can we change the definition of what vision impairment really is to include aspects of cortical vision impairment? Rachel also pointed out the importance of early intervention and really taking advantage of those early years where neuroplasticity comes in and where children's brains are so placid and able to make those new connections that can actually help them to learn. We need to know and use the assessment tools that are out there to diagnose and to provide interventions for children. And we need to develop more tools. There's a great need for more and more complex assessments for CBI. We also need to develop the interventions to support progress. Many of them are out there, but there needs to be further dissemination of these interventions across a variety of communities in eye hospitals and education settings in order to give the children the access to that early incidental learning that is their foundation for all the concepts and learning that they will use to grow and to thrive. And finally, the importance of education and social inclusion. We need additional education approaches that are really based on the neuroplasticity research and therefore the connection between the research and the practice. How can we give children with CBI better access to learning by using strategies that help them to see and therefore be able to take that information in and learn so that they can meet their greatest potential? And how can we share all of the tools that we have in our toolbox with each other so that we can develop further programs and better programs for children with CBI? What does the future hold? So there's been so much progress made in the area of CBI over the past 20 years, but there's still a lot of work to be done. There is a lack of widespread information on CBI. You'll find in communities where there's a knowledge, where people understand CBI and can assess, there are diagnoses of children with CBI, and in other communities, there are none. We need more research and information sharing among the global community of eye care professionals and educators. We need more collaboration between ophthalmologists, research, and educators to provide the full spectrum of services that children with CBI need. And we need increased recognition of CBI in the eye care community as a whole. Perkins School for the Blind has been working with children for CBI for several decades and has become known as a center of excellence in CBI diagnosis and intervention. However, in the past year, we have made a further commitment to play a significant role in the spread of information of CBI and support to families and children in the US and across the globe. Perkins has committed to building a Perkins School for the Blind CBI Center. And it's in progress right now. Some of the pieces are rolling out as we speak and in the past few months. One of the aspects of the center will be essentially a learning lab. As we are already working on clinical assessments, diagnoses, and intervention of children, it will be a place where more children can come for those services. But beyond that, the professionals who serve them will also be able to come to be able to work alongside the ophthalmologists, the educators, the therapists, to learn so that they can bring that knowledge and skill to their community. There's a focus on integrated assessment. Again, talking about going beyond the clinical assessments and really looking at functional assessments, looking at how children, not only how are they seeing, how are they learning, and how can they better use their vision to learn. There'll be additional e-learning opportunities, although I will point out, please, to check out the Perkins.org website, as there are many e-learning opportunities already there. Some are accredited courses, some are quick, short courses, but there are several for you to take advantage of. The advocacy and collaboration is a big part of the new CBI Center. And as you'll see on the screen, CBI Now is a portal right now for parents. And it has information about CBI. It has wonderful information. I go there often myself to look at the latest research, to learn about new strategies, what are families saying. So I encourage you, as well as professionals, to use this as a resource for CBI. The idea is the more that families and professionals know about CBI, the more that they can advocate for their children to get the services that they need, and that will pave the way for children in the future. The goal of the center is over the next 3 years to reach 50,000 children who have CBI in the US. But the other goal is also to reach children beyond those children in the US and to influence the international community, the global community, and bringing research and practice together. So please visit the CBI Now website, check out the resources there. I wanted to thank you so much again for being with me and for being with the whole team of us here today to provide additional information on CBI. Please reach out if you have any questions or ideas or thoughts. I would be more than happy to meet you and to discuss further. Thanks so much. Enjoy the conference.
Thank you, Sovita, and thank you, Kristen, for a very informative lecture. It gives us an overview of how we can help the children and the parents of CBI. So if the courses are available online, and many of us ophthalmologists can join those courses, we can use those applications, apps. It'll be very, very useful. So we have the next speaker, Ms. Paige Closton. Maybe you could share your screen. We will take questions and discussions at the end. And let's finish the presentations.
Sure. All right. Thanks, Dr. Suma. And thanks to the conference for having us today. Before we jump into further details on CBI with our other colleagues, I'll be introducing our screening module for multiple disabilities with vision impairment, and how that relates to the identification and management of CBI. So this is a screening module that was developed for a joint project between Perkins India and Dr. Shroff's Charity Eye Hospital, a project we called Project Identification and Intervention, or Project IDI. So we use the term MDVI to refer to multiple disabilities with a vision impairment. So this means that somebody has a combined vision impairment with at least one other disability. So for example, it could be a vision impairment with an intellectual disability. It could be a vision impairment with a hearing impairment, which could also be called deafblind, vision impairment, and cerebral palsy. And just as an example, here are some of the children that we've encountered in our work. So up on the top left, we have Rashmi. So she's a young girl with a vision impairment and a hearing impairment. So again, deaf blindness. Up on the top right here, we have a girl who has cerebral palsy. So that affects her mobility. And then she also has a vision impairment. On the bottom left here, we have two kids who both have intellectual disabilities in addition to their vision impairments. And you can see they have kind of varying degrees of vision impairment. And then on the bottom right here, we have Julie. So she actually has a vision impairment, a hearing impairment, an intellectual disability, as well as cerebral palsy. So you can see there's a lot of diversity in this term of MDVI and the kids that we're seeing. So I'd like to recall the quote that Kristen Layton shared when she said, "You've met one child with CBI, you've met one child with CBI." And exactly the same thing could be said for our children with MDVI. So for each child, their combined disabilities and challenges will interact in complex ways, which each require unique and specialized interventions to make progress in their development and their learning. So CVI falls under this umbrella of MDVI because many children with CVI will exhibit delays in one or multiple areas of development, such as their motor, their cognition, or their speech. And many will have these associated disabilities like cerebral palsy or intellectual disability. And as Madhumati ma'am will introduce later, that's why it's so important that we take a holistic approach to interventions with these children with CVI or MDVI. So even though not every child with CVI will have an additional disability, we still generally consider them to fall into this category of MDVI. So our project IDI is a community project. So the community screening, it follows a very similar process that you might be familiar with in other community programs where screening is done out in the community. Children are at-risk cases are referred to the eye hospital, and then we assess the intervention and enrollment that's needed from there. So it's a simple enough model, but I just want to point out some of the key elements that make it very, very effective. So first is building trust in the community. So we rely on door-to-door screenings using key informants instead of large-scale screening camps. So for this, we use key informants like Gram Pradhans, ASHA workers, Anganwadi workers, or other important members of the village. And these key informants direct us to the households of children with disabilities. And because we rely so heavily on these important community members, it's essential for us to build trust with them, and then their trust allows us to interact with families in the community. And another key element for this project is the training of our CBR workers and the special educators in the project, because they really become the first point of contact for families in the community. So we have to train them on disability, functional disability generally, as well as the intervention strategies, which Madhumati ma'am will get into a little bit later. And in our community screening, we teach our CBR workers and our special educators, it's important to cast a wide net for picking up cases in the community. So we're not just looking for children who we think have a vision impairment, but we want to look for any child with a disability because so often there's a vision impairment that's not considered in children who have other disabilities. For example, if a child has an intellectual disability that's very obvious, people might not think to assess that child's vision. So that's why we concentrate in these 8 different domains of disability that are listed on the screen here. So we have a very detailed screening form that our field workers take with them. And for each of these 8 domains, we have a list of items, of about 6 to 10 items that can flag children as being at risk for these different disabilities. So just as a quick example, here's the checklist that we have for vision and hearing. So it's just very, very simple functional items or behaviors that children might exhibit that could point to the child's disability or other health issues. And when we're out in the community, it's not our goal to diagnose a disability right there. And that's not the role of our CBR workers or our educators. We simply want to be able to flag these cases at risk so we can refer them for further assessment. And again, this is just a piece of that form where we're very clearly marking off and indicating children who are at risk so that we can refer them, which brings us to the next important key element, which is once they complete that referral, they should go to the hospital for a complete clinical and functional assessment with trained professionals. And these clinical assessments, of course, will help determine any medical interventions the child might need, such as glasses or a surgery. And here it's very important to point out the capacity of our vision technicians and optometrists on the project. They've been specially trained on how to do clinical assessments of children with disabilities. You may be familiar with cases when a child is deemed untestable or uncooperative during a vision assessment, but we never want to let that happen. So our vision technicians are trained. The assessment might take a little bit longer. It might take a little bit more creativity on the part of the VTs, but we want to make sure that no child goes left untested. In addition to the clinical assessment, we do an in-depth functional assessment in all the different domains, which will help determine what, if any, additional interventions are required. And Dr. Savita and Marumati will dive in much deeper on what these assessments look like. Our final key element for this project is making sure that we provide the services, or at least connect the services to the child for depending on whatever his or her needs are. So depending on the results of the clinical and functional assessments, we develop a unique plan for each child and their family. And this might range from helping the family obtain a medical disability certificate to helping the child enroll in school, or to obtaining assistive aids and devices that will help the child learn. And for those children who do have MDVI or CVI, we enroll them in the early intervention sessions. And what has this resulted in for our project so far? 1 year into the project, and even despite the limitations of the pandemic, we have been able to do door-to-door screenings in 126 villages in Mathura. We've screened 416 children in the community, flagged almost 200 to send to the hospital, completed clinical assessments for 124 children. And of all of those kids, we've found 63 to have MDVI. And I know those might look like small numbers to some of you, and you might be thinking it's a lot of effort to go door to door just to find 63 children in the community. But with this project, we know that we must meet children where they're at, or they're going to have little chance of succeeding and getting opportunities to learn. Because from our data, we've seen that children with MDVI are more likely to be out of school compared to all other children screened. So that means they're less likely to be found at screening initiatives like school screenings or screening camps in the community. And even if they were in attendance at some of those screening events, there's a good chance that they might go untestable or uncooperative and be skipped over. We also know that we have to meet these children where they're at in the community, just because stigma is so high about disability and awareness is so low. So that's another reason we focus on going into the community. And this whole project, as I've just outlined, we were happy to share that last week it just got recognized by the UN as a good practice towards achieving the Sustainable Development Goals. So we can see on a global level that this really works towards some of the SDGs like good health and well-being, quality education, reduce inequalities, and partnerships for the goals. And I'd just like to close my part of the session by acknowledging that this has fallen on a very auspicious day, which happens to be Helen Keller's birthday, who I'm sure many of you can recognize as the world's most famous deafblind individual who went on to be an author and a leader and an advocate. Also a week that we celebrate deafblind awareness, which we'll be posting about, so you can come and check us out and help us spread awareness about deafblindness. Reflecting on her early years of learning, Helen Keller wrote, "Once I knew only darkness and stillness. My life was without past or future, but a little word from the fingers of another fell into my hand and my heart leaped to the rapture of living." So this just makes me think of the kids in the community who are out there maybe in darkness, and we just want to give them a chance to leap to the rapture of living, just as Helen Keller had. So I will wrap it up right there. Please don't hesitate to reach out if you have any questions, and I'll hand it back to Dr. Suma. Thank you.
Thank you so much, Paige. That was really wonderful. Again, we stress more and more this instruction course is not only for to help us as ophthalmologists to just do clinical assessments in the clinics, but it is so important that we go into the community. See, you can well imagine in 146 villages, we found 63 children who have not been treated till now, and they were hiding in the community. So it is so important that we screen these children and we assess them and we intervene and treat them. So this highlights the importance of CVI, of multiple disability with visual impairment. It tells us that there are so many children still in the community waiting to be helped. So I would say that we would take it much further by by having more programs, such innovative and such beautiful programs where we are helping the community at large, where we take into effect the training of the CBR workers, which is so important. And the pandemic taught us that even door-to-door screening could help us treat these children and relieve them of their problems. So I would now present, let us go to a little bit of theory for us to understand what exactly is CVI, and hoping that we can detect these children and bring them to the early intervention specialist, or we can help them by treating them much earlier. So why is CVI now becoming important? Because why is everyone talking about CVI? We find that in India, with improved management and survival of children affected by brain injury due to perinatal insult or other metabolic disorders or trauma, it is becoming the cause of visual impairment in our population. And along with that, we find that even in a multiple disability with visual impairment, many of them are children with CVI. So if we have to make assessment, we have to manage such children, though it is a very challenging field, but we need to move forward. So what is it? It's basically a deficiency in the function of vision due to damage or malfunction of the visual pathways and visual centers in the brain, basically just for those posterior to the lateral geniculate body. So it is a big umbrella which covers a range of visual processing difficulties. So now it is not only vision, as we ophthalmologists are taught that everything is 6/6 vision, but there's a lot into it more than vision of 6/6. So how do you differentiate it from ocular visual impairment? I would not go much into details of this, but the one pearl which I would like to say is, if your ocular findings do not explain the visual difficulties of the child's parents or the parents' concerns, please look out for CVI. If the response to your treating conditions, ocular conditions, are usually suboptimal, we find that the rest of the structures of the eye may be normal. They may be associated cataract or optic nerve abnormalities, but the vision response, the visual behavior is much more profound than what we see during the ocular examination. There's a latency for the visual response. The visual attention span is poor. The difficulties in crowded places. So all these make it much more difficult to assess, and also much more difficult for the parents to understand what exactly is the problem. So this is because vision is not only what we see actually 6/6. It is like there are multiple stations in the brain, the occipital lobes, posterior parietal lobes, and the temporal lobes, where we see a clear picture in the occipital lobe. The colors are appreciated, shades of gray of the contrast are appreciated, and also helps us to have a wide view of things, which is the visual fields. And we find that if any of these factors are effective, and if there's a damage to the occipital lobe by some problem during the antenatal or perinatal or postnatal period, they have problems in inability to perceive colors, inability to appreciate objects with less contrast, and visual field effects. And just imagine how a child could function without these basic vision processing in place. So it'll be so difficult for them to see a blackboard. Maybe I just see one side of the blackboard, or maybe I don't see my inferior field. I cannot walk properly because I'm not able to judge what is there, what I'm seeing below in the inferior field, or I'm seeing everything blurred. There's a contrast problem. So these are issues which the intervention specialist helps us to manage. Because we will just be doing the assessments and we will be plotting the range of vision processing difficulty, and the intervention specialist then finds out, okay, this is the problem, this contrast is poor, or the color vision is a problem, how to help the parents, guide them to how to help the child manage these problems. So the posterior parietal lobes it connects the occipital lobe with the posterior parietal cortex, and it tells us where we are. It helps us to guide the body movements. Like a simple thing, like in the OPD, we do Lydia symbols, which we have made it just, a child has so much problems with just, putting the pieces in the right places. So this is how we assess. This child had very good vision, 6/9 vision with the glasses. And we found that, but he still had problems. He had a hemiparesis on the right side. He still had problems in just putting these simple objects into the right places. And imagine how would he be performing in school then. So these are the problems which parents come and tell us that what is happening with my child. Damage to the posterior parietal lobes also helps causes simultanesia. What it means that I see one object, I'm able to pay attention to only one object, but the surrounding objects, if there is a lot of cluttering, if there's a lot of crowding, I'm not able to place my position in them, and I get confused. And we find that even the inferior field, like imagine climbing down the steps or walking on the road, how difficult it may be for the child if there is an inferior field defect. So now the Lydia mailbox in the OPD can help you find out if there is optic ataxia. See, this child is able to orient the slot and turns the card appropriately to correct position before putting it into the slot. So this visual guidance of movement is called, when there is an impairment, it is called optic ataxia. And see, this child, the child cannot exactly position the card in the correct position. The temporal lobe, when it is affected, it is like recognizing colors, shapes, objects, numbers, letters, facial expressions. So it's so important that if we have to recognize a person by the face, or we need to recognize objects or letters, numbers, I may even need to find my route to where I'm going. I may lose my route. I want to go home or to want to go to any other places. I get confused in a crowd. So how do we help such children? So vision, as you know, I can recognize the pencil here by the temporal cortex. Then I know that the frontal lobe chooses the pencil, and then the dorsal stream, that is the parietal occipital lobe, instructs me, okay, where to reach for the pencil, how far to reach, how to position my hands and fingers to grasp this pencil, and then the task is completed. So it's such a difficult process, and it's such a difficult thing, that process in the brain which is occurring. But we don't realize it because everything is for us very easy. So this task is what is difficult in a child with cerebral visual impairment. And this is what the therapist or the early intervention specialist helps the parents. They tell them, okay, this task is difficult. We will teach the child how to improve on this task, how to guide them to help them with this task. So the etiology is, we need to ask the birth history in all these parents of what was the cause, whether there was hypoxia, there was brain damage, there was infections, or hypoglycemia, a simple thing which we found was more common in India, and seizure disorders. So you suspect in all children with unexplained bilaterally decreased vision. Other acquired causes like a head injury, if there's a cardiac arrest, focal infection, epilepsy, or encephalitis. So we find that when in the late second to third trimester, when they're affected because of hypoxia or ischemia, it causes periventricular leukomalacia, and at term it causes encephalomalacia. So in our study, we found that, which was published in the Journal of Pediatric Ophthalmology and Strabismus, we found that maternal hypertension was the most common cause. Even in our preterm study, we found that cerebral visual impairment was seen in 22.5% of children. So when we go to screen children with ROP for ROP screening, we inform the parents at there itself that please, these are children who are born preterm. They may be at 6 months or at 4 to 6 months. They may have delayed milestones. If they have delayed milestone, please come to the pediatric center and come to us for checking the vision or assessing the vision. Because it might be missed. You may diagnose it maybe at 2 years because you do not feel in between that the milestones are not proper. 90.9% are eventful antenatal periods. So all this can be captured during our history taking. So global development delay was seen in 22.7% of children. So what are the red flags to detect? So we need to know the normal milestones. RBSK has given a nice manual, and these are distributed in all their centers. They have child development centers all over India. We need to distribute, and we need to make all of them aware that if a child has no eye contact, no social smile, no awareness of hands, there is squinting when you see it before the age of 6 months, not reaching out to any object, then there's a red flag that they need to show a pediatric ophthalmologist. If they're not recognizing faces at 7 to 9 months, they're not picking up objects from the floor, they're pointing at pictures. They do not respond to mother's gestures, and they do not follow simple things, or they do not walk steadily. They have trouble in climbing up and down stairs. They cannot eat without help. All these are important red flags that we should pick up and refer to the center. So this is how we can detect and what are the causes. So now we go to the next part of a course. Like when these children come, what are the ophthalmic manifestations we see? How do we assess them? So that is how we will guide our ophthalmologist and in assessing these children with CVI with simple tools. We do not want big tools, but with simple tools, if we can help during this course, help some of the guide many of the ophthalmologists and how we can pick them up easily in the clinic and help these children. I would go over to my next speaker, Dr. You could share the screen. She is a pediatric ophthalmologist and a neuro-ophthalmologist at Dr. Shroff Charity Eye Hospital. She will be with a very keen interest in neuro-ophthalmology, and she's very good with children. And we find that we need to detect these children because it requires a lot of patience, and she will guide us in this course. What are the ophthalmic manifestations we can pick up, and how do we assess them? Over to you, Dr. Sovita.
Good morning, ma'am, and thank you for this opportunity. Is my screen visible and am I audible?
Yes, please go ahead.
So now we know what is CVI and what was MDVI and what is the importance of these children. So I would re-emphasize that CVI is a true visual impairment. Also that these children are our special children. So parents come to us with the complaints that the child does not have a good eye contact, or they're unable to grab objects to hold their toys. Apart from this, they would come with a complaint of cataract or white reflex, squinting or shaking of eyeballs. So what are the known ocular associations is reduced visual acuity, or they would have crowding phenomenon. They would have reduced contrast or the optokinetic nystagmus, altered fixation, altered perceptual abnormalities, abnormal smooth pursuit and saccadic movements, and strabismus, nystagmus, and altered stereopsis. So what literature says in this paper by Jacobson is that the most common visual field, most common ocular association was reduced visual acuity, and the least common what they found was reduced visual field. Unlike this, but we find in our clinical scenario in a day-to-day practice that most of them, these children would definitely have a field defect also, as mentioned previously. Now we go on to assessment. So to assess these children, since these are special children, as I said, what we need is that we need a room which should be clutter-free, which should not be very compact with toys, and the examiner should wear a cloth or an apron which is dark or a uniform shade. This would mask the patterned appearance, and not very bright ties or not very toys which would make a squeaking sound. So we would prefer to use targets which would have facies, and these facies would have discrete features like eyes, mouth, nose, because the child starts appreciating or gazing at the mother's face in the beginning and knowing these features. So by fixation, we would want to know the visual sphere, at what sphere the child starts working or prefers to look at objects. Then we can go ahead with the visual acuity. We know these are the standard tools which are available. In children, we would use paddles like Lydia gratings. This video would show how the Lydia paddles are used. These are based on preferential looking test, where there's a controlled diffuse background paddle and alternate black and white striped, where the thickness decreases gradually. And as we try to do this test, we would see that first we should sit at the parallel level of the child, and both the paddles are held such that, both the paddles are held such that the control paddle is on the first and the striped one is hidden behind it, and then they are swapped across and look towards which side the child prefers. It can be done both uniocularly as well as binocularly. The other modality which we routinely use is TAC, which is again teller's acuity card based on preferential looking. The examiner here is trying to appreciate the response of the child through the peephole, whether it is preferring to look the stripe patterns or the diffuse background. Again, this can be done both monocularly or binocularly. Other cards which uses vanishing optotypes for a little older children or for milder CBI are CAT cards. Allen's or Lydia symbol can also be used, as we know. They can do Lydia matching at the beginning. Another important tool is optokinetic nystagmus, which when rotates would elicit a fast following movement, a slow pursuit movement, and a refixation movement, the saccadic movement. The response would be in the form of nystagmus. Once this optokinetic nystagmus or response is elicited, it gives us the intactness of visual pathway. In older children, Sling, Snellen chart or E-chart can be used. However, one would prefer to give them single optotypes to get a better response, since they would have crowding phenomenon. Now, VEP is another objective tool to assess visual acuity in these children. It would give us the intactness of the visual pathway. More so, the flash VEP would just give the response, and a sweep VEP is preferable because this gives us with a rapid sweep within a 10 seconds duration, where these children would have a smaller attention span. So this is how the levels of visual acuity in CVI children has been quantified in a paper, right from light perception to occasional fixation to level 5, where we see the visual acuity is between 2050 to 2200, and level 6 is normal sensory examination. Then when we start doing refraction, we need to do one static retinoscopy followed by cycloplegic retinoscopy. In cycloplegic retinoscopy, one should remember that the cycloplegic agent used here is not cyclopentolate, rather homide and atropine, which does not have any neurological side effects. Near retinoscopy is a must in these children because they would also have accommodation problems. So what literature says regarding the refractive errors, in preterms, myopia and its association with ROP was more common. Children with PVL who have escaped severe ROP, hypermetropia was found to be more common, along with astigmatism. And children with CP also had hypermetropia, and accommodation insufficiency is seen in most of these children. So assessment of accommodation is done using a RAF ruler or by dynamic retinoscopy using monocular estimate method, where initially we ask the child to fix it on a near accommodative target, then look back at a distance and again at the near target, so that if there is any accommodation lag, we would know by the movement and then prescribe any hyperopic glasses or bifocals. So this was a paper from our institute, where we found that refractive error, the most common ones were simple myopic astigmatism and compound myopic astigmatism. Color vision assessment is also done in these children using Ishihara pseudoisochromatic test or the Farnsworth test. But more important is the contrast sensitivity, because we see most of them would have reduction in contrast sensitivity, and also because the daily facial expressions day-to-day activity are typically of low contrast. So what we use is the Lydia low contrast symbols or the Lydia grating test. It has been seen that the hiding Heidi test has a positive correlation with the Pelly-Robson chart, and hiding Heidi test has with higher contrast with a darker background smiley, which is altered or swapped right from the dark one till the less one. We have to see if the child can attain till the level of 2.5% contrast. Field effects are more common, and this can be elicited right from the history, whether they are tripping over the floor or difficulty in walking downstairs. Most of them, as discussed, would have inferior field effects due to superior periventricular damage, would also have right homonymous hemianopia. Tests used depends upon the age, the degree of severity of CVI, whether Humphrey confrontation can be tried in older children, the leg raise test, puppet facies, and the Lydia wand test. Here we see for a children, a 2-pencil confrontation test is done, and the other target is moved in all the quadrants, asking him to testing his fixation or the field effect till where his eyes can move. This is an illuminated target, which is called the Lydia wand, which is brought superiorly, inferiorly, right gaze and left gaze to assess which field is affected. In this video, okay. So field effect, we would try to take a smaller target, which I can show with a board or some obstacle here, and move the target up or down and watch how this child is moving her eyes. Sometimes a child will move in all the directions except at one direction, where we know that this is the field which is affected. Apart from this, pursuit and saccades are also affected, as discussed. And so one would have to move the head rather than moving only the eyes. So we would know that there is a head thrust to look at an object. In this video, we are trying to assess pursuit and saccades, giving him a target and seeing how the child is following the target which is given. Now coming on to strabismus, isotropia is most commonly noted. Exotropia is seen is constant and associated in severely affected patients. But the classical nature in these cases is the dyskinetic strabismus, and there is an angle variability, the shifting pattern that at few visits we would see that there is exotropia which would have changed to esotropia in the subsequent visits. Assessment of strabismus is little similar to what we do routinely. However, in these children, most of the assessment is based on the corneal light reflex tests, the near cover test. We have to do repeated assessment before we decide on any surgical correction to attain a stability of deviation. Ocular examination is must, assessment of pupils, and anterior segment examination either using a portable slit lamp or even a distant direct ophthalmoscope when children will not be able to sit on the slit lamp, and for fundus examination to look out for disc pallor, any macular pathology or retinal pathology, previous laser scars. We have seen that in optic disc findings in early PVL are small hypoplastic discs, whereas in older children, they would have normal discs with large cups, which were initially known as pseudoglycomatous appearance. Now they are classically called as PVL discs. So to summarize, these are the neuroophthalmic associations of CVI. They would have gaze deviation. This is based on the level of damage, whether it is cortical or subcortical. They would have nystagmus, strabismus, and optic disc abnormality. So I would just like to conclude that, again, what Helen Keller has said, it is not just one examination, but it is the team effort, what we are trying to do, that alone we can do so little, but together we can do so much to bring in smiles in the parents of these children and make these children at least confident to face their peers. Thank you.
Thank you, Sovita, Dr. Sovita, for an excellent presentation. Before we go to the next, we just discuss for 5 minutes before we go to the next talk, because we'll complete the ophthalmic manifestations. Key pearls, what I would like to just emphasize on is, on Dr. Sovita's presentation. One thing is that we need to assess, do the refraction. Vision has to be assessed first. So the vision is very important. We cannot, because parents are mostly concerned is what is the vision of my child. It may be that when we do with the Lea pedals, we might find there's a difference in vision of both eyes. So it is important to also treat amblyopia, because even if we find that if there's a difference in the refractor of the two eyes, and if there is we find that the child has any significant refractive error difference in both eyes, we need to give the glasses and also start amblyopia treatment. So we cannot say that, okay, these children will not be benefited. Yes, these children will be benefited, and we may need to do patching therapy also. So glasses have to be prescribed according to age appropriate. And Dr. Sovita nicely pointed out that we need to do MEM or monoestimate method we have to check the accommodation, because most of these children have accommodation lag. So what we find is that if you may need to give a plus add to these children along with for near, especially for near, because we find that most of these children are doing near activities. And if they do not, if you add a more plus, they really, and if they have an accommodation lag, you can see their faces brighten up. You can say that the parents say that, okay, now they've started looking at objects more clearly. They see the objects much clearer. So this is very important for us to help the parents to give them bifocal glasses, or maybe only a near glasses in the initial period, and then maybe shift them to bifocal glasses. The other pearl is basically like when most of these children are diagnosed by ophthalmologists as glaucoma patients because of the appearance of the disc. And Dr. Sovita nicely pointed out that these are pseudo-glaucomatous disc. So Dr. Sovita, one question to you: when you have a child, what is the imaging which you prefer, and what exactly, why do you want the imaging to be done?
In today's condition, imaging is more important to give them a label that these are cortical visual impairment, because imaging will tell us where the pathology exactly is, whether it is a subcortical damage, whether it is a periventricular leukomalacia, or whether there is some gliosis, encephalomalacia, apart from other syndromic children. So that will tell us which lobe is affected, how can we prognosticate their children regarding their functional vision assessment, based on which we can focus on what exercises we would give to. This is also essential to educate the parents.
So any specific you would tell what should we as ophthalmologists write for what specific scans we want, like when we are asking for an MRI?
So we would request an MRI brain, With contrast is okay. If they do without contrast also, to look out for changes of hypoxic ischemic encephalopathy, which would enlist PVL, encephalomalacia, gliosis, or any corpus callosum abnormality.
And do you think VEP is helpful in these children? Because do we take it as a guide for any measure, for any therapies or any guidance to tell us about anything?
VEP will just tell us whether the pathways are intact, but it has been seen only when we do repeat VEPs, as their functional vision improves, even the repeat in VEPs, their waveform also improves. So this can be again to give us a clue that yes, there are, if the waveforms are coming, that means it has some chance, or we can still educate the parents and do a repeat VEP to know whether the child is really progressing. These all would actually counsel the parents also more. We know that the child is CBI, we know the diagnosis, but still.
One pearl I would tell is that if your VEP is coming extinguished also, do not discourage the parents. Means like I would say that we should still motivate the parents that there is still hope and we need to really still start early intervention programs. And even children who we have operated for cataract, and sometimes we do find that they are not performing as well as we expected for them, visually. We might need to assess their developmental skills even after, say, we have given the appropriate glasses and after 6 months we find that still the child has not started walking or not, the visual behavior is not as appropriate. We may need to early intervene. So in strabismus, what is the guidelines you find that do you undercorrect them or do you give it, because in strabismus, or when do you already have said very nicely that we need to reassess them multiple times. Like we cannot just give it we cannot assess them one time and we go ahead for surgery. We may need to assess them multiple times before we go for surgery. So any surgical protocol you will be following?
We try to undercorrect them because they have high chances of consecutive exotropia. Yeah. So what is recommended is 10 to 30%. Depends from child to child based on a measurement, and other factors of refraction also would come into account. Unless and until they are very significant. But general norm for esotropia is undercorrection. For exotropia, it has not been found. And we do follow that.
So we go to our next speaker. Very nice. Thank you, Dr. Sovita. And we go to our next, I think, Ms. Madhubati Bose, who would be speaking to us about how to manage these children, the most difficult part, how to manage these children. So,
yeah. Sorry, can I just share the screen?
You have already shared your screen. You just have to do a slideshow.
Okay, I can't find the slideshow anyway.
It's at the bottom. It's at the bottom, doctor.
Oh, God. And, anyway, namaskar. It's a privilege and an honor to be part of this forum and especially of this team, part of this team.
Slideshow.
Sorry?
Full slide, please.
He's asking you to go for the slideshow. In your computer, there may be where you can show. See, there's a slideshow animations, and then there is slideshow written here. Go up in the file, home, animation, slideshow. Just click on the slideshow.
I don't have slideshow. Otherwise, I would have.
Doctor,
no, there is in your. I can see your computer. Yeah, that's a slideshow.
Okay,
click on it.
I was being silly, so sorry about that.
Okay, fine. Now you're perfect. Perfect.
Thank God. So can I start again? Namaskar. And it's a privilege to be part of this forum and especially of this team, part of this team. So I have divided my talk into three. One is three parts. One is the assessment. The second is the intervention, and then the success stories. When we talk about, when we're talking about the assessments, it's important that we learn about the characteristics, which Dr. Suma has mentioned also. One is that our children with CVI, with cerebral visual impairment, they have this shows strong color preference, need for movement, visual latency or delay, visual field preference, difficulties with visual complexity, need for light or light gazing and non-purposeful gaze, difficulty with distant viewing, atypical visual reflexes, and difficulty with visual novelty. They do not respond to any new stimuli easily, an absence of visually guided response. Okay, assessment of CBI characteristics. We cannot talk about assessment of CBI characteristics without mentioning Kristen Roman-Lansky. Kristen and the CBI assessments go hand in hand. So the Cdi Range is the assessment protocol. It is used to measure the functional vision of a learner. It identifies the typical characteristics of CBI that are present in a child. It also evaluates how these typical characteristics influences or impacts the child's or the learner's functional vision. Research has proved that the results are consistent and reliable measures of functional vision. It's a favorite of mine. Why? Because it measures the functional abilities. It's been a systematic guide to me to know my children better, to understand them, to chart their progress, and of course, guides me to understand and to do their programming. It's the ability of the learner and not the age that it focuses on. Parents are part of the assessment, and it's so good to involve them not only at the center but during the home visits. It is flexible and it is not rigid that you need that particular kit. A kit is suggested and the items are suggested, but it's not a rigid rule. Also, it has to be this variation. You have the opportunity to do it in different sections. Like at home, this thing at a noisy environment. Okay, next please. Okay. CBI assessment protocol. It has two methods, CBI rating 1 and CBI rating 2. Rating 1 it identifies the typical characteristics present in the individual. And CBI rating 2 is an overall degree of this characteristic which impacts the learner. It is done through its observation, interview, and direct contact. I love the importance given to parents' interview because it's the parents' interview, the way the interview is conducted, it is more for supporting the parents, for the parents to learn to know their child better. Range is also determined where the characteristics are resolved, child's present level, plus and minus is partially at that level, and minus means it does not apply, it's too high for the learner. CBI rating is from CBI 1 to 2 is from minimal visual response to 9 to 10 is where it functions visually. Like minimum response will be the child is seeing only objects at near distance within 18 inches. Functions visually is beyond 20 feet. CBI 2 is the characteristics are scored on a categorical scale from 0 to 1 with increments of 0.25. This is the degree, the overall degree that impacts, that each characteristic impacts the learner. Okay, environmental consideration is we know that the environment affects a child with CBI's visual input. It either helps or it disrupts the functioning of the visual functioning of a child. Many a times the parents have said, "Ye acha dekhta hai jab ghar mein koi nahi hota." It's because the noise has been reduced, movement has been reduced, the child sees better. It's divided according to the levels of level 1, level 2, and level 3, according to how much of adaptations and accommodations are needed in the environment for the child to see. Cbi Resolution Chart. This is a favorite of mine. It's the sum of all of them. It's a comprehensive information regarding the child's visual functioning. It helps in planning programs and also helps in specific activities to help the functional visual abilities of the learner. But I want to tell you this, the resolution chart is much more than just the parts. The whole is more important than the parts. Improvement in the Cbi range, I want to show you this. This is little Agastya. He was 5 months when he came. And today so this is at about range 1 and this is at 7 to 8 when he's looking at the mirror. So I'm doing the description in details. Color preference. Our children prefer yellow, red, then they go on to simple patterns and multiple colors. Need for movement. Sorry. This also tells you about the field. Latency, visual latency or the delay. Lots of our children show latency. The latency is also observed when the child is tired or ill or has been overstimulated, which is many a times we special educators and working in vision therapists, we have a tendency to do that, overstimulate. Okay. Field preference. Difficulties with visual complexity, objects. They prefer looking at single colors, simple patterns, rather than complex ones. Difficulties with array, where like this little baby there's so much of stimulation that he refuses to look. A black background helps. If the things are illuminated, it helps. If the objects are illuminated. Sensory dysfunction, removing sensory distractions, it helps. We feel the child is not seen, but it is actually the sound at the back that is distracting the child. Difficulties with faces and making eye contact. This actually makes the parents very sad कि बच्चा मुझे नहीं देख रहा, बच्चा मुझसे नजर क्यों नहीं मिला रहा. Need for light. This is an unpurposeful, non-purposeful gaze, but they're just looking at light or they're looking at objects where there is no, without actually, it's like looking through instead of looking at. Difficult with distant viewing. Atypical responses, where when anything comes close to our face, we have a tendency to blink, or when you touch the bridge of the nose, you have a tendency to blink. But our children with CBI miss on this. Difficulty with novelty, visual novelty. Here the child is looking at the golden stimuli, but as soon as I present a new stimuli, the child refuses to look or is unable to look. I won't say refuses. Absence of visually guided reach. We sometimes use vision to, auditory to get the attention of the child, and then we slowly fade it away. You can see that Uzma is aware, she's following, but when it comes to touching, she looks. This is actually, you look away and touch. This is the things, the three words that describe the absence of visually guided reach. Look away and reach. Finally, yes, brilliant. Okay. Now we go on to the stimulation, the interventions. Interventions, it's never too early to start. With the survival, like Dr. Suma mentioned, advances in medical care has led to the survival of infants. Preterm infants in low birth weight, small for gestational age, and a lot of children with syndrome. Visual intervention should begin in the NICU with visual protection and visual stimulation. Please remember, visual protection is just as important, protecting them from unnecessary light. The number of children with multiple disability and cerebral visual impairment has increased, just like Dr. Suma said earlier. Like Paige mentioned, the effects of vision or vision impairment, it affects the holistic functional development. You cannot stimulate 9 to 10 is visual stimulation only with a torch. It affects the social emotional when there is no eye contact. It affects the language, cognition where the child cannot see or recognize the objects, activities of daily living, gross and fine motor activities. Vision is for doing. For us as professionals, we need to motivate the child to see. We need to make it useful. We need to integrate it into the everyday activities. It has to be throughout the day. Like I said, it cannot be 9 to 10 and evening 4 to 6 is vision therapy, and the rest is not important. Vision therapy has to relate to the child's environment. The child has to enjoy, it has to be exciting, it has to be meaningful to the child and functional. Only then will the therapy help. Change the environment and not only the child, and not the child, not only the child, but not the child. We expect the child, ye karega, ye nahi kyun karta, but we haven't changed the environment at all. It follows a process depending dark room, semi-dark room, normal and outside. You cannot just say just because he can see it in dark room that he has. Like assessment, visual intervention should be done in noisy as well as calm places, outside, inside, with moving objects, with stationary objects. So with light, without light, stimulation, use black background, illuminate the toy, build up the visual, this thing by lighting up the stimuli. Lighting up, please do not use objects, put the torch directly in the child's eye. Use movement, sound, and touch to get the child to respond and then fade it off. Do it in different postures. Because a lot of our children, they may be seeing in line, but when they're sitting or crawling, they stop using their vision. Material, use simple, common material, common things that are available in the environment. Fruits, vegetables, anything that you get. Do give the children breaks. Please remember that. Make the child comfortable. Use the child's own toys or equipment to make the child feel at ease. Use colorful, bright, fluorescent toys and material. Use a board because our children have distant vision, they don't have, so they tend to come forward to look. So use a wedge which helps them to maintain their position. Use contrast. This is very, very important. Don't use mobiles to stimulate. Don't use LED lights. Don't use Diwali lights or Christmas lights. They are vibrating. They affect the vision, or they affect the child's, because the child it may lead to seizures, and especially for a child with seizures, Diwali lights and vibrating toys are a big no-no. I love this because I'm wearing yellow. And during assessment or intervention, please do not wear brightly colored clothes. In fact, the thing that Paige showed, I'm wearing yellow in that also. Terrible. Wear black so that you do not distract the child. Avoid clutter. It's important that the child has a clean and a clear environment to look at. Each child is unique. Now I go to the third part, the success stories, and each journey has a different story to tell. Here I want to say that I'm showing the success stories, but not all the children reach up to the level of 9 to 10. There are some children who, because of sensory the dysfunction or because of seizures, some of them do not progress as much as we would like them to. But they have, the potential is lost because of the other comorbidities. This is Vehant. He was absolutely, he was normal, he's going to school, I hate the word normal, going to school, and then he got pneumonia and got a stroke. He lost all his functions. His mother is actually behind him. Literally, I think she's dedicated like all parents for the. This was exciting because, you know, from the right peripheral free, he's getting it, he's looking with the left also. Knowing the field is very important, not only to place the objects in that field to begin with, but also we need to develop the other field. Our children with CVI, they get the sides as well as they get the superior. Their inferior, like Dr. Suma mentioned, is the problem. Walking is a problem. Looking down at objects is a problem. And of course, he's very naughty, so please don't be taken in by his, innocent looks. And he loves, working and proving himself, which is fantastic. This is Rishabh. I may have seen these videos 100 times, but every time I'm just as excited, and I hope they, anyway. So he may be in reading without and writing without any adaptations, but walking, he needs adaptations, especially in an unfamiliar place. So that's where the resolution chart comes in. You know exactly how to plan. Oh, sorry. This is Mishti. They come from Haryana, and we are walking for a vision out, in the open, outdoors. We are working on her distant vision as well as her visual complexities, the visual array. This is quite brilliant because yellow ball and yellow leaves, yellow and brown leaves. I wasn't sure whether I'll get it, but she did. This is Oops, sorry, really sorry about this. This is little Vedic. Oh, has it stopped?
Madhumati ma'am, let's go a little bit faster.
Yeah, I finished.
Yeah. So I think
oh, sorry. I need
it's okay. It's by wonderful videos and we are all learning.
4 minutes, right? And please, and I had that mistake that I made earlier. Sorry. This is visual complexity. Again, array. Can you see the clutter at the back? Please don't do that. This is, we are working on fine motor also with vision. There are times when she's not looking and she's using just a touch, and it happens a lot with children with CBI.
I think we'll have to fast forward this because next is Dr. Amanjit Siota's session. So because we have another just 2-3 minutes.
I would like to thank our parents and our children. Without them, without you, we are nothing. And thank you. This is our team. Thank you to all for believing in our work. And I have to say something about the Vrindavan team is that in spite of the lockdown, they made home visits and they saw all the children and they didn't ignore, they made telephone calls also. Okay, thank you. Thank you very much. And it's been a pleasure. Thank you.
Thank you so much, Madhumati ma'am, for the wonderful videos, and the amount of patience and work which she treats these children is really, really commendable. We are so thankful to her because most of their children are, they have really have improved, and then we start the treatment of whatever is required for surgery, for squint surgery or whatever, or if the child has any other problems. But early intervention is the key for treatment of CBI. Any other questions? We have very few questions and we could answer them in the chat box. And Mr. Prasad, when do we, I think we'll have to give over the podium. And for concluding remarks, I would like to thank all the speakers. Please put the videos on, and Madhumati ma'am, please put your video on. And we would like to conclude the session. Mr. Prasad, over to you.
Thank you so much, Dr. Suma. Thank you so much to all our speakers for keeping it on time, and we can hand over the session to our next speakers on time. That was really great meeting you all and seeing you all. Thank you so much.
Thank you so much.
Thank you, ma'am. Thank you, everybody.
Thank you. Bye.
Thank you, everyone.